Hello. Today we're going to talk about alterations in elimination, specifically urinary functioning. This is in chapter 26. The first thing we're going to discuss is urinary tract infections. They may involve the lower or upper urinary tract. Infections may be confined to the lower urinary tract, such as cystitis, which is an inflammation of the urinary bladder, and urethritis, which is an inflammation of the urethra. They may be followed by recurrent episodes without long-term consequences. Infections of the upper urinary tract, which include pyelonephritis or urethritis, are associated with or may result in permanent renal damage or scarring. Uncircumcised males under 3 months of age and females younger than 12 months of age have the highest baseline prevalence of urinary tract infections. 83% are caused by E. coli in females and 50% in males. Signs and symptoms. Lower urinary tract infections are often characterized by symptoms of irritation to the bladder, such as hesitancy to void, dysuria, frequency of voiding, and urinary incontinence. Upper urinary tract infections or kidney infections, also called pyelonephritis, tend to present with fever and may lead to renal scarring that may be associated with decreased kidney functioning, hypertension, and renal disease over time. Upper urinary tract infections may also present with additional symptoms of flank pain, nausea, or vomiting. In your text, box 26-1 has the clinical manifestations of urinary tract disorders or disease. The neonatal period, birth to 1 month of age, poor feeding, vomiting, failure to gain weight, rapid respirations, respiratory distress, spontaneous pneumothorax, frequent urination, screaming on urination, poor urine stream, jaundice, seizures, dehydration, other anomalies or stigmata, enlarged kidneys or bladder. Infancy, 1 to 24 months of age. So note that we typically see an infant as 1 to 12 months, but here they're using 1 to 24 months of age. The signs and symptoms here we would see are poor feeding, vomiting, failure to gain weight, excessive thirst, frequent urination, straining or screaming on urination, foul smelling urine, pallor, fever, persistent diaper rash, seizures with or without fever, dehydration, enlarged kidneys or bladder. Childhood, 2 to 14 years of age, poor appetite, vomiting, growth failure, excessive thirst, enuresis, incontinence, frequent urination, painful urination, swelling of the face, seizures, pallor, fatigue, blood in the urine, abdominal or back pain, edema, hypertension, and tetany. So diagnosis, really it is a positive urine culture. And probably the most accurate test of bacterial content are suprapubic aspirations in children under 2 years of age. And then bladder catheterization, but please remember to discard the first few milliliters of urine. Avoiding cystourethrogram, also called a VCUG, may be done to determine abnormal retrograde flow of the bladder urine into the ureters. This procedure requires a child to have a catheter in place prior to going for the exam. An intravenous pyelogram and ultrasound may also be done. If a child requires an IVP, please make sure to assess for allergies, past reactions to contrast, and pregnancy if age appropriate. So the typical treatment is oral or IV antibiotics. If there is a defect present, then they may need to have additional treatments to prevent further infection and kidney scarring. Nursing, predisposing factors. So let's prevent urinary tract infections if we are able to. So what kinds of things predispose people to have urinary tract infections? Number one, females have a short urethra, which is close to the vagina and anus. So here we want to check for vaginitis or pinworms, especially if the child is scratching in between their legs. Avoid hot tubs, whirlpool baths, water softeners, bubble baths, and bath oils. Also recommend frequent pad changing for girls who are menstruating. So for the problem of incomplete emptying and overdistension of the bladder, here you want to avoid holding the urine. Encourage the child to avoid frequently, especially before a long trip or other circumstances where toilet facilities are not available. You want to take time to empty the bladder. This may be helped by a relaxed toilet posture for girls. That this posture is with the feet supported on a stool and the knees are apart. Have the child double void, and this is where you will void, and then you're going to wait a few moments and then void again. Severe cases may require clean intermittent catheterization or biofeedback instruction. The next issue is concentrated urine. Here, to fix that, we want to encourage generous fluid intake. Acidifying the urine decreases the rate of bacterial multiplication. An acid ash diet, which consists of meats, cheese, prunes, cranberries, plums, and whole grains, may also be beneficial. Another issue can be constipation. So we want to ideally avoid straining during, excuse me, during defecation and avoid constipation. We can do this by encouraging a high fluid, high fiber diet. And then this will help to prevent problems with constipation. Please note that routine circumcision is not recommended by the American Academy of Pediatrics. You can treat bladder spasms with warm compresses unless the fever is present initially. So if they have a fever, we don't want to put something warm on them. And as a nurse, it is very important for us to assess their voiding patterns. Next, we're going to talk about hypospadias. And this is a birth defect. It is a urethral opening located on the underside or the ventral side of the penis. The diagnosis, this is diagnosed at birth. We do not circumcise this child because you may need the foreskin for corrective surgery. Treatment, they may apply testosterone cream to enlarge the penis so surgery is easier. Pubic hair will disappear and the penis size will return to normal once the cream is stopped. Typically, surgery is performed between 6 and 12 months of age so the child can urinate with a straight stream in a standing position, and they will also straighten the penis if a chordate is present. A chordate is a fibrous band under the penis causing it to curve, and this is done to preserve future sexual functioning. Nursing, so we want to check vital signs, strict intake and output, check the urinary stent. Sometimes this may just be a catheter, which stays in place for 5 to 10 days. They may need restraints to prevent them from pulling the stent or the catheter out. Pain medications, muscle relaxants, antibiotics are typically in place. They'll be taken until the stent falls out or the catheter is removed. We do want them to avoid a straddling position for 2 weeks. Double diaper to protect the stent and collect the urine. Urine will be bloody for a few days, and watch for signs and symptoms for infection. The child is usually discharged in a day or so. Give the parents the above discharge instructions, and please note that ditropan or oxybutynin may be prescribed for bladder spasms. While they're healing, they may apply petrolatum jelly or KY jelly to the diaper to prevent the penis from sticking. This can also help to prevent bleeding and increase comfort. Cryptorchidism. This is when one or both testes fail to descend from the inguinal canal into the scrotum. This normally occurs between 7 and 9 months of gestation. About 75% of cases spontaneously descend by 9 to 12 months. If the testes do not descend, an orchiopexy is performed as soon as possible after 6 months of age and definitely should be completed by 2 years old. So treatment, I just mentioned, is surgery. It is done on an outpatient basis. Post-operatively, they will apply ice to the area, pain management. A few days later, checking for those signs and symptoms of infection. And they also want to restrict activity for 2 to 4 weeks. When assessing a child, place them in a warm room because a cold room will draw the testicles closer to the body. Please note that parents are very anxious because they are fearful their child may have a decrease in fertility. These patients do have an increased risk for testicular cancer and a decreased fertility in bilateral cryptorchidism. Nephrotic syndrome. 80% have a primary disease called minimal change nephrotic syndrome. This is most common in 2 to 7-year-olds, twice as often in boys and girls, and for a nonspecific cause, the glomerulus is damaged. This damage causes increased permeability of the glomerular membrane, and that allows albumin to pass into the urine. The kidneys resorb salt and water. Protein deficiency leads to decreased osmotic pressure, allowing fluids to escape into the tissues. Massive edema results. A loss of protein leads to decreased immunoglobulin and then increases their susceptibility to infections. Signs and symptoms here: weight gain, puffiness of the face. Occurs especially around the eyes. It's more apparent when the patient wakes up in the morning and subsides during the day. Abdominal swelling, pleural effusion, labial or scrotal swelling, edema or intestinal mucosa may cause diarrhea, anorexia, and poor intestinal absorption. You may also see ankle and leg swelling, irritability, easily fatigued, lethargic. The blood pressure may be normal or slightly decreased. They are at increased risk for infection. And then the urine alterations, here what you would see a decrease in volume and frothy looking urine. Diagnosis: history and physical, low albumin levels, and then proteinuria greater than +2, as well as hypercholesterolemia. The treatment objectives for therapeutic management include reducing excretion of urinary protein, reducing fluid retention in the tissues, preventing infection, and then minimizing complication related to therapies. Prednisone, which causes diuresis in children and the mechanism is unknown, is typically given daily for 6 weeks and then alternate day doses for 6 weeks. 25% albumin IV may be required. Diuretics may be used for edema, and note that relapses may occur when the child gets their immunizations, if they suffer from allergies or infections. Relapses rarely occur after puberty. Nursing: we want to monitor for the intake and output, the abdominal circumference, the specific gravity of the urine protein. We want to give the prednisone as ordered and monitor for side effects such as moon face, increased weight, increased hair growth, mood swings, elevated glucose, elevated sodium, decreased potassium, elevated blood pressure, and growth retardation long term. Prevent infection and skin breakdown. They may need to be turned every 2 hours because of the edema that can cause an increase in skin breakdown. The child should be on a low sodium, fluid restricted, and regular protein diet. Teach the parents the medication regime. Make sure that they check the child's weight daily, abdominal circumference, and then they also need to check the urine dipsticks. If it's +2 for protein, they want to give the doctor a call because that can indicate a relapse. We also hold immunizations until the prednisone is complete. The last condition we will talk about today is acute glomerular nephritis. This is also called AGN or acute post-streptococcal glomerular nephritis. Here, the child develops a streptococcal infection. They then get better, and then 10 to 21 days later, the child develops AGN because immune response antigen antibody complexes are deposited in the glomerular basement membrane. This causes inflammation and obstruction. The peak age is 6 to 7 years of age. Boys twice as often than girls. Diagnosis is hematuria and proteinuria, maybe +3 to +4, elevated BUN, elevated creatinine, a tea-colored or cola-colored urine, an elevated white blood cell count, elevated ASO titer. This demonstrates a previous streptococcal infection, and a renal ultrasound. Please make sure that you do know the normal labs for your exam. The BUN for the newborn is 4 to 18 milligrams per deciliter. An infant and child, 5 to 18 milligrams per deciliter. Uric acid is 2 to 5.5 milligrams per deciliter. The creatinine in the infant is 0.2 to 0.4 milligrams per deciliter. In the child, it is 0.3 to 0.7 milligrams per deciliter, and the adolescent is 0.5 to 1 milligram per deciliter. Other signs and symptoms you want to pay attention to would be things like edema, especially periorbital. Facial edema, again, is more prominent in the morning, and it may spread during the day to involve the extremities and the abdomen. The urine is a cloudy, smoky brown, as I mentioned before, a tea or cola colored, severely reduced volume. They may have anorexia, pallor, irritability, lethargy. This child really appears ill, although they seldom express super specific complaints. Vomiting is possible. They may have mild to moderately elevated blood pressure. The older child may complain of headache, abdominal discomfort, and dysuria, vomiting possibly, and they also may have a mild to severely elevated blood pressure. The treatment, bed rest, antihypertensive medications, possibly diuretic use, and fluid and sodium restriction. They may be on a low potassium diet, as well as if the protein, and a low protein diet if they have an elevated BUN or azotemia. Meals are typically small and frequent, and recovery takes a few weeks. Nursing, vital signs, again, monitoring the weight daily. This is the best way to determine weight gain or loss. Intake and output, edema, checking the abdominal girth. Make sure the output is at least 1 milliliter per kilogram an hour. Maintain skin care. Due to the bed rest and edema, we want to make sure that we are turning them at least every 2 hours. Quiet activity until they are better, and then slowly increase activity. We do want to prevent infection due to the decreased renal function resulting in an increased risk. Check specific gravity, check for signs and symptoms of infection, elevated temperature, malaise, elevated blood count. Teach parents medications, side effects, diet, how to assess the urinary dipstick, blood pressure, and signs and symptoms to call the physician. A relapse may be occurring if the urinary dipstick measures +2 for protein for for 3 or more days, or the child is found to have a +3 or +4 protein plus edema for just 1 day. Complications include peritonitis, cellulitis, pneumonia, circulatory insufficiency due to hypovolemia, and thromboembolism. Please note that fluid volume excess is related to a decrease in plasma filtration, that is, a decrease in the glomerular filtration rate. As they improve, the urine output will increase. So that is it for alteration and elimination, specifically the urinary functioning. Please make sure that you watch all of the videos that are related to this week. Thank you.